Okay, thank you very much. Now we'll move into the Q&A. And just to start, I have a question for the panel, I think for all three, and then I hope all of the audience also has questions as you've heard their presentations. I'll just start with one, and you alluded to it at the end about the initial cost of the technology. That is a concern and seems to contributing to the health disparities. Can anything be done about that? Because not only, you know, we have the technology, but there's costs for the technology, the data charges, et cetera, et cetera. What can be done about that?
Make it cheaper. No. I mean, that's something that we've been concerned in related to all of our projects, that there's the cost of the device, there's the cost of the data plan, there's the cost of training, there's a cost of storage, there's all the add-ons. And so one of the reasons why we selected an iPod as the technology for this project was that it could be used disconnected and still have connection. You can add on a GPS unit only for when you need the GPS unit because it doesn't come with a GPS chip. So that keeps the cost down. And it's a tool that they can continue to use and not have additional charges for. It's the same thing on the software side. So we use Magpie, which is a free software. It's a nonprofit that continues to build on it, was used for health workers in Africa. And so you can have the full functionality of a very robust survey interview tool, but it's free and you can customize it to what you need. And so these are tools now that the tribe has access to that they have now are customizing for a different purpose in the same project. But whatever we can do to sort of reduce the ongoing cost and maintenance costs for technologies for underserved communities, I think we need to explore those options.
Thank you.
I would also like to add that there are advantages to, I would like to also add that there are advantages to just using short messaging because you can use them not only on a smartphone but also on what we would call a dumb phone, and we don't necessarily need that mobile application.
I think it's, well, you know, I'm not a tech expert, but of course I think the recent decision around making equal access to the internet was probably very historic. But secondly, I think in terms of health plans, and this came up earlier, particularly a prepaid health plan like Kaiser Permanente, there is a question of whether we should look into whether that barrier is tied to our ability to deliver on improved outcomes. So just as we look at co-payment for certain tiers of drugs, there probably should be a question of what's the co-payment to access into our membership portal. Whether there's any aspect of subsidizing facility in terms of getting into the system. And some people have argued now that it's almost a human right now to have access to information as much as a human right to have access to health, access to food, and access to security. Information could be potentially seen as a human right and a really critical part of in terms of maintaining health.
Thank you. Good points brought up. I'll ask one more question, then we'll go out to the audience. I wondered about what the challenges are in conducting the research with your mobile strategies that you've just discussed.
Well, I'll start the discussion. I think that traditionally we believe that randomized controlled trials are the way and allow us to have the strongest science. However, with using mobile technologies, oftentimes it's difficult to be able to fund those RCTs as well as collect the data, as well as the data is not necessarily lends itself, it may not lend itself to an RCT because you're collecting real-time data. So I do think that there is a need for rigorous evaluations that might be in lieu of RCTs. As we enter this field and we need some data, we need some evidence, I think we may need to think about how we plan our evaluations accordingly.
Thank you.
I would mention two things, and one of the sound bites I didn't get to say while I was talking, so I get to do it now, is that it's not just health literacy on the part of our participants and our users, it's actually community literacy on the top part of the researchers. So someone mentioned provider communication. I think we as researchers need to have cultural humility around what we don't know, and have some literacy around how best to engage community if we want these sorts of interventions to work in the best way that they can. In relationship to the mobile technology, so we're doing a number of projects now using mobile and social technologies and iPods, cell phones, smartphones, tablets, computer, web-based applications. Every one of these devices and every one of the applications running on those devices has issues with acceptance, usability, and usefulness for our participants. And so it's not access to the device. It's not just access to the device. It's not just access to the information, but it's actually the usability and usefulness of the entire package, which is why I think the Gates Foundation work was so interesting and important. So as a research tool, the mobile technology and social technology can be fabulous, but as Betty just said, the RCT is so further down the line that if you don't get adoption, if you don't get the actual feasibility issues worked out, you'll never get to that RCT. So I think there needs to be literacy on our part as to how best to implement these things with community so they can get to feasibility, that then will eventually get to the RCT.
Thank you. All right. Thanks. Now we'll move to the audience. We have a question. If you can state your name and where you're from and
Absolutely. Junyang Wang from the FDA. One of the things I'd like to thank the panel before I begin my questions. It was a very interesting talk. And one thing that I wanted to speak on, I think, is a two-part question that Winston, you referred to before when you were asking a question last panel, was how do we really look at subpopulations and minorities? How do we get them to enhance the robustness of clinical trial data? Why is it important, and how can we increase numbers, and where do we go with increasing those numbers? I know we have all these strategies with enhancing. It's always great to get more participants, but is there like a right number that we're shooting for, and how many times can we really divide the pie? Because when we're talking about minority health, or we're talking about men versus women, we're talking about genetics, we can divide it as many times as we can, as we want, right? And so what factors do you think are really the important ones to consider? Because in a RCT, there's only so much that you can do before, like a priori, before you actually start your trial.
So you expect me to answer my own question? Actually, I thought our panelists did a marvelous job of answering in terms of trying to get down to a level of community participation. But having said that, I think there is a critical question with regards to the current way that we do cut the pie. And, I've been talking to some interested colleagues of mine around even the issues, and, it's probably pretty obvious, but when we look at Asian Pacific Islanders, that group is so heterogeneous. It includes folks from India as well as people from, Okinawa, Pacific Islands, et cetera. So when do we start understanding that a grouping of Asian Pacific Islanders has probably very limited clinical significance in terms of the natural history of disease? So there is a political issue with regards to what the importance is of disaggregation of what are the commonly used racial and ethnic categories that we use in the United States. And I use API as an example, but I actually think in the increasing diversity of our current populations, Latino, dare say Africans, African Americans are a heterogeneous group now, that there is not only a political issue, but also a methodological issue with regards to how we understand the importance of disaggregation. I'm not a research scientist, so I don't know where the p-values start to get diluted, but I think we have to make the commitment to understand in the United States, as probably the most unique population in the world, that we can't really unroof what are the hidden disparities until we understand the science of disaggregation.
And if I could just follow up with this, I wanted to thank Dr. Kim for her introductory comment that was, you said it's not just about the stereotype, there's a type as well. And I just wanted to go along and further ask you, because this is a health literacy workshop and roundtable, one of the things the FDA is doing is really posting like demographic information of the clinical trials for the public in what's called the drug trial snapshots to see who was involved inside the clinical trials. It's part of the FDASIA Section 907 initiative. Look at me speaking like a government already. But the whole issue really is, how do we communicate that type of a nuance to people? Does it really matter to people? Will they look at this data in a way that will help them in their kind of medical decisions? And does that benefit, or is that, as maybe as Winston mentioned, is that exacerbating the problem, trying to make it much harder for people to actually answer their health questions?
I think erring on the side of access to information is better than lack of access to information, because you're worried about whether people will understand it or not. And as part of the workshops that we did with the Karuk Youth Partners, we talked about data, information, what you know about your community, what you don't know. And through doing this research project, at the end, they said, I had no idea how much people were actually concerned about obesity in our community. And you might know that, obesity among Native American youth is extremely high, and this particular population is about 80% of all youth. And so they kind of know it, they kind of see it, but they didn't actually know how much the community cared about it. And then when we were able to say, well, in fact, this is a national concern. You can look at the national statistics and compare your local community with national statistics on Native Americans. How important does that feel to you now, and what do you want to do about that? So it's, I don't know about the particular data set that you're talking about, but I do think that having some context about what information is available that you can actually use to think about technology and think about health interventions in your community is very beneficial to those people trying to make a change.
Thank you.
Thank you. We'll go over here.
Yes, my name is Lindsay Robinson, and I represent the American Dental Association on the roundtable. I am the dentist in the group, and I have to thank you, Dr. Kim, for finally putting oral health out on the table and making it part of the conversation.
I also floss.
You are an outlier, let me tell you. So, but this segment is particularly important in terms of thinking about the disease of dental caries, because 80% of the disease burden is in 20% of the population. And in fact, the CDC released data a couple weeks ago, 2 years of NHANES data, that showed that there's been a modest improvement in the reduction of prevalence of dental caries in young children in the Caucasian population, and a marked reduction in terms of untreated dental caries in the Caucasian population. But in terms of Hispanics and African Americans, disparities still exist in the young population, the youngest children. And in the Native American populations, it's just beyond, it's off the reservation, I guess. I mean, it's just phenomenal. Sorry about that. But when you think about Native Americans, in some tribes, over 75% of the children under the age of 3 they need to be treated in the operating room because their early childhood caries is so severe. I mean, it's just highly prevalent. So it was really nice to hear that Text for Baby had an oral health content piece to it included in that. And so I guess my question is to Dr. Kim, in terms of the Native American population, was there anything incorporated in the research that was done around oral health? Or how can we reach that population in particular, messaging, trying to reduce the prevalence so we don't have the disease burden so high, and the impact on families so great around especially early childhood caries?
I don't know that I have a specific answer to that, but from the experience of having worked with these youth in the Klamath Basin, it is amazing what they come up with when they start to brainstorm what are the potential questions, issues that we might want to explore. So, oral health did not come up. If we were to do, more with them and talk about, in general, health disparities beyond food insecurity, which is really was our focus, and we had more time to think about other things that impact health disparities, it might have come up. But our role as the facilitators of this project was not to push them to think about an issue that we thought was important. It was really to let them come up with those issues and to provide technical assistance as to how to answer the questions that were important to them, that they thought would impact the community. So I don't think I have a specific answer other than this sort of general CBPR sort of principle and approach, but bringing as much of the technical assistance around how you answer rigorously a question that you are concerned about, and then allow that to be their guide to drive their own research agenda.
I like how you said you let them drive their own research or ask their own questions, but I have to wonder if they know the prevalence of, the oral health. That the statistics were amazing. Any other comments?
Well, I mean, I haven't worked on this particular issue among the Native population, but I went to Alaska earlier in 2014, and one of the things they pointed out was when they looked at the skulls of Alaskan Natives just 2 generations ago, there was hardly any evidence of dental caries, and now almost all the kids have dental caries. So, Dr. Kim would be the expert more than me, but I think the cultural embracing of history and the elders really comes into play here, potentially with the Native populations, because the elders probably say we never saw people with rotten teeth until the introduction of Western diets.
Yeah, thank you.
I think Jem was.
Oh, he's first? Okay.
Yeah.
I am Jem Doss, also on the Roundtable. So, Winston, you mentioned that the digital technology or the reliance on it has the potential to exacerbate health disparities, and this is for all of you. But I'm wondering if you can give a specific example, and I'm not just trying to find out sort of what disparities are exacerbated, but how. What is it about the way that digital technology is employed or whatever that continues to exacerbate those disparities?
Well, I'll take a shot at it. I think a lot of what we discussed earlier with regards to early adopters and people who are able, and I was actually during the presentations, I looked up Maslow's hierarchy again, right? And when you look at Maslow's hierarchy, the top 2 parts of the pyramid are social and self-esteem. I think there's one other one. Actualization. And it seems to me that those 3 parts of the top of the pyramid have a lot to do with the people who are wearing their Fitbits. And really, right? Because if you're really worried about food, you're really worried about safety, probably purchasing the Fitbit is not the top most priority. And so there is, I think I see it in San Francisco, the heart of the digital divide almost, because you see so many individuals who have invested a lot in terms of their self-fitness and wellness, whereas we have probably one of the worst homeless populations in the city, in the country. So there's a divide, and there's an exacerbation with regards to the disparities, because we do see the fallout between people who are really high accelerators and early adopters of self-actualization strategies, as opposed to population level strategies to increase the wealth of health across a different community. So that's really the definition of health disparities, is a community that has disparate outcomes and well-being at both sides of the spectrum. So, that's just my first shot at it.
Any other?
Yeah, not in our work with the Native American community, but in another project that we also did in San Francisco, which was around youth with obesity and depression, and implementing a mobile application for them to do self-tracking and look at their own patterns and work with health coaches. One, we did have good, outcomes, actual health outcomes related to that, but the one that was most striking was the increasing levels of patient activation. And I think that activation came from a couple things. One, from the qualitative interview data that we have is, one, I've never before had a person who just wanted to listen to me, and that was the health coach. Two, I got to look at my data and decide what it meant and where I wanted to make a change, if I wanted to make a change. And so it was all sort of internally driven. And then they had a tool that actually let them pinpoint what action they would take and what was having an impact and what wasn't. So I think that self-efficacy, very related to the Maslow's hierarchy, that activation is what I hypothesize is what will drive the long-term impact on their health. Not just the short term in our intervention, which was only 6 months, but the long-term impact on their health. So if you think about access to that sort of intervention, along with the technology, and again, we used iPods, so it seems to be the thing that I like to use, but technology, access to that information, access to the intervention would not have occurred had there not been a wonderful funder, Robert Wood Johnson Foundation, to sponsor it. That is not something that the public health department can afford to do. They can't buy these devices for every young person in San Francisco, in Healthy San Francisco or Medicaid. And so that is something that we know works well on a small scale for underserved youth. We can't scale that unless there is a funding source to do that. So that would exacerbate, I think, the digital divide and the health disparities divide.
Thank you. Okay, and we'll take one last question, then I'll turn it over.
Rob Logan, National Library of Medicine. I have one question for Dr. Wong and one question for Dr. Kim. Dr. Wong, the large HMOs have reported more success over time with patient portals and health IT interventions than really any other healthcare institutions in the U.S. They happen to be clustered often in the western part of the U.S., but they're not exclusively there. I've always wondered if that, and I'm asking for your opinion now, we're not really in any more in a factual situation, but is that because possibly people have to make a commitment to be a member of those organizations in the first place, okay? Then those organizations wanted to show, they were early on in investing in, when to show a return on investment. They had a very large a number of users, and to me, those are different sets of circumstances than a lot of other healthcare organizations have to work with. But just curious whether or not you think that's relevant.
Well, thank you, Rob. I do think what you raise is relevant, and let me provide some context to this. So, Kaiser Permanente, which is the largest member-related health plan, we had 9.6 million members. We did market surveys, of course, and there's actually a cachet of the population, 70% that say they will never consider Kaiser Permanente. So we actually know that there's a culture, if you will, of people who don't like the aspect of joining a plan and having a specific network of physicians. Now, the other 30% that consider Kaiser Permanente, and 30% of California's patient population is Kaiser Permanente members, there's a very little migration rate, a very low migration rate. So people who stay with Kaiser Permanente stay with Kaiser Permanente. And why is that so? It's because of the connotation that you made, Rob. People think of their relationship to Kaiser Permanente as a member, as opposed to being a patient, as opposed to being a consumer. And I think the member affiliation makes it easier to connect to people in terms of why would you want to have reminders? Why would you want a health plan to tell you that you should walk or exercise 30 minutes a day? You have a different orientation to your relationship to the health plan. And I don't think Kaiser Permanente is the end-all be-all for everybody, et cetera. But I do think there's an aspect of investing in one's health. So I had a very short conversation with George Halverson about a month ago, who used to be our CEO, and he said, you know, I was talking to someone, he says, why do you guys do this? He says, Kaiser Permanente is actually invested in making sure you live long as opposed to seeing that you get sick, because we don't make money if you get sick. We make money if you just stay healthy. And that's, of course, probably the foundation of how the most historic HMOs have really always been established.
Thank you. For Dr. Kim, first of all, thank you for citing our work. We appreciate it. The challenge we find in doing intervention work in Native American communities is actually the Native Americans who don't live on the reservation anymore, but live in urban areas. In case the audience doesn't know, the statistics in urban areas for Native Americans are actually much worse, significantly worse than reservations, and the lowest apparently ever measured among any group of Americans. Okay, there the statistics are even more frightening than the ones you cite in your presentation. The problem we find is you can intervene on the basis of a sense of community in some reservations, but with urban Native Americans, okay, that sense of community may not be there because they're from all over the country. They may represent 60, 80, 100 tribes. They may represent Native Alaskans and Alaska Natives and Native Hawaiians, and there may be other complications. So I'm curious, the model you described, a lot of it has to do with a sense of community that people might feel and appeal to. What happens when that is diluted significantly?
Yeah, thank you for bringing that up, because one of the things I wanted to mention is my children are actually Native American. They're 1/16 Native American. So they're not represented in that 3.7 million because they've never identified themselves as a Native American on any census survey or anything. And that's often what you see both in the reservation communities and in urban communities, that they are, their identity is multiple. And so you might not even know how many people identify as Native American because of that. So how do you engage a community when you don't know where the bounds of the community are and which community you're identifying? And I sort of compare the work with the Native American youth in the Klamath and the urban youth in San Francisco. In San Francisco, it was not an ethnic identity that they felt. What they felt was a school community. So we had students at the local high school, and we had other youth that were part of the San Francisco General Family Health Center. Honestly, the ones at the Family Health Center felt no sense of community. They were the hardest to engage and keep in the intervention because their primary relationship was with a primary care physician that they rarely saw. In the school, they did have a sense of community. We are members of the school. They were all Latino, African American, Asian. So it wasn't around the ethnic community, it was around the school community. And so I think you have to think about the community that you're trying to engage, not necessarily the ethnic group, not the, to me that's a type, not a stereotype. A school is a type of community. It is not the stereotype in which every school community is like every other school community. So I think it's that definition, and it's by going to them that you find out where the bounds of their community are.
Thank you.
Thank you. I want to thank my panel again on the right. If we can give them a hand, and then we're going to move it over to general discussion.
Don't thank him yet because I have a few more questions.
You got more questions. All right. Thank you.
So I just wanted to ask a question or two. And to this question, maybe Dean can be part of the panel. You can stay where you are, but maybe you can answer this. There probably is not an ROI for the private sector to be encouraged to develop health literate apps, especially for some of the select populations that we've just discussed. And yet, because they don't see a big market in that area. Yet, we know from the discussions we've had a few moments ago that the greatest health disparities may exist in this area. So therefore, we would look for more chronic disease in that area: hypertension, diabetes, renal disease, HIV, tuberculosis, et cetera, et cetera. So, what can we do about that? How can we convince the private sector that there is something to be done in this area to help healthcare in this nation?
So having spent most of my career in the private sector, and now being back in academia, it is definitely driven by not necessarily return on investment, but profit. And I think that there's money to be made in population health. What the business model is, I don't know yet, but there's money to be made in population health because we're all trying to improve the population health. There's research monies going into that. There's health system monies going into that. There's, public health department monies going into that. There's another meeting going on where Gary Wolf from Quantified Self is over there. He thought he was in this meeting this morning. So I thought we were going to have this conversation, but he wasn't. He's in the other one. And he has this other, a group that he's convened, and this is the second year they're doing it, and there's one in San Diego in either April or May, where they're trying to have this conversation. How do you bring the public health people, the community health people, together with the technology people to say, not just what are the needs in the community, but how do you actually get the technology companies to address those needs, and where does that business, the business model come from? So I don't have an answer, but we spend so much money on it, there's got to be a way that we build a model that incentivizes companies to take that on.
Dean, any magical touch to that? Yes, I'll get to
I'll try. Dean Hovey. I think I'm going to get this right. Ray Charles, great blind musician, singer, had a not-for-profit that he supports, and it had to do with the deaf people. You think, isn't that odd? But he did it because he valued his hearing so much because he was blind. And I guess what I was thinking about is sometimes there are small populations, but there are groups that care. And I'll go back to what I said before about the United States. I think people do want to serve and help. So Robert Wood Johnson is a great foundation. And I think what you need to do is identify those that care and stimulate that as well. Now, the stuff that I'm doing for profit certainly has spillage over into the other situations. Sometimes you can't afford the technology. I remember Apple was always generous to give computers or get people started in classrooms with their computer. There was a profit motive behind that. So I guess that would be the thing that I would look at as well, as figure out who cares and then go after that way. And there will be people in the technology sector that care if they can find another partner that cares.
Winston?
So 1/3 of all Californians is actually covered under Medicaid right now. So by definition, that's a low-income population group. So, quote, there is money there. Now whether there is profit there is a different question, but there is money there. I'll also reference, I have a family member who works in part of a big retail company that actually markets to our lower income community. And I think part of this Wild Wild West is there's going to be some segmentation with regards to how technology is starting to be parsed out to different population groups based upon their discretionary income. Just as there isn't retail. Most of us do not shop at Neiman Marcus. I think most of the people here probably shop more at Macy's, but there's a lot of people that shop at Walmart. And Walmart is not the same population as Neiman Marcus. So, that's in my crystal ball. I think there might be some aspect as the technology really starts to unfold and how segmentation becomes more obvious that we could see how this will penetrate into different communities.
I just wanted to, I always go back to a quote from our founder, which is of George Merck, which is, medicine is for the people, it's not for the profits. And when we've remembered that, the profits have followed. And that really is something that I hear almost every day in our work. And I just wanted to also say, and you're right, people are sick, right? And it doesn't matter who those people are. They still need medicine. They still need help. And disproportionately, they may be generics but we still have an obligation to make sure we help treat people in the right way. A lot of the work that I've been leading for the last several years has been thinking about how do we apply really a universal precautions approach to our communications with patients, whether it's in patient education, in the space of clinical trials. And I hope that ultimately that has a disproportionate benefit on people with low health literacy. So that's one of the other things that, thinking about how does a company communicate in a simple and clear way with all persons can, I think, help with this. Now, from a digital health technology, nobody in a big company is fast, and I think that's a challenge with digital health, quite frankly, right? And somebody earlier today said, you have to move quickly, and quite frankly, in a large pharma company, that's hard. Right, so that to me is as much of a barrier as anything. So anyway, I just wanted to throw that in.
Thank you very much. Thank you very much, Pamela, for coordinating and putting this all together, the panel. And thank you to the panel, Catherine, Beth, and Winston. Really much appreciated.